colonoscopic EMR. It's a papilloma of the rectum where you do an endoscopic mucosal resection. You can see a nice EMR being done there in the rectum. And hepatobiliary. This I will touch a little bit. Indications for an ERCP. Biliary stones, pancreatitis, calculus pancreatitis with a large stone obstruction. Bile duct injuries. Here I want to stress a point is particularly young surgeons who are doing laparoscopic cholecystectomy, bile duct injuries are very important. You have to be very careful. Bile duct injuries can happen even to the best of the laparoscopic surgeons. If somebody says that I have never had a bile duct injury, that means he has not done enough number of gallbladder surgeries. That's what I would say. So this is how ERCP, that is endoscopy, is very important in these cases. Here you can see a nice huge stone that is being removed by doing a balloon extraction after a sphincterotomy. It is a sphincterotomy being done. And post-lap chole bile leak. We do get a lot of cases of post-lap chole bile leak. The drain would have been kept and the drain doesn't come down at all. 300 to 500 ml of drain keeps draining. Then what we do is do an ERCP. There will be a stone obstruction in the distal CBD. Remove the stone, keep a stent there. The patient will go home fine within 3 days. And cholangiocarcinoma, complete obstruction, inoperable. Do a metallic stenting and come out. And pancreatic stenting is very rarely done. A large stone obstructing the pancreatic duct, producing calculus pancreatitis. Remove the stone by doing an ERCP. The patient will have complete remission of symptoms. This is how a pancreatic duct stenting is done. I think that's enough for the today's lecture. Thank you so much. Thank you, sir.
Thank you, sir, for your beautiful session. I request Dr. Ramesh to honor Dr. Govindaraj and present a memento to him.
I really thank Dr. Govindaraj for given a wonderful lecture in endoscopic surgery.
Thank you, sir. Now I would like to welcome Dr. Ishwaramurthy, MS laparoscopic and endoscopic surgeon, to present his session. I welcome you, sir.
Dr. Ishwaramurthy is an out
for all these surprises. Surprise number one, like in airport, how they are able to see that you have traveled out, because they usually recognize by your retinal image or your thumb impression, because they compare your thumb impression or your retinal image to hundreds and lakhs and even a crore of people. In a matter of few seconds, the computer will tell you who you are. That is called pattern recognition. That is a little rich, because if you are a radiologist, you know, if I throw 100 mammograms, tell which one has a lesion, it will take at least a day or two to go through the whole picture. But if we give the same thing to a computer, in another 2 minutes it will tell is suspicious or strongly suspicious or malignant process. So without even taking a biopsy, I'll be able to tell the patient the likelihood of the serious nature of the tumor. So that's the way we are going to do. That is, computer is going to help us a lot in making a diagnosis, not alone your own experience and expertise. And that is the first thing. The second thing is about the chip, because I am here in Karaikudi, everybody knows, thanks to the GPS, because the phone I am carrying will tell me where I am standing. So in other words, you can't hide in the world anywhere. That is where, because the chip is everything. So I'll tell you a simple case. Here is a patient who had a hysterectomy done. Few months down the line, she came with a lower abdominal pain, and we opened, we found, very sorry state, that an abdominal pad was misplaced and it was actually inside the patient's body. We had to remove it. So we know at the end of every operation, nightmare of any surgeon is not leaving either an equipment or a gauze or a pad inside the patient. That's why we are very religiously, we have a way of doing things. Like for example, we have a standardized counting procedure. We ask the staff nurse, have you counted before and after? In spite of all the careful checks, still at the long day, mistakes tend to happen because we are all human beings. Mistakes tend to happen. One way of preventing from tomorrow is what we call a magic wand. That is, every gauze piece will have a chip inside. Okay, if you leave that gauze piece inside, by the time when the patient's abdomen is closed, it will make a beep noise saying, I am still hiding inside, please take me out. So that is called a smart sponge. Every sponge will have a chip. So that will tell you. So at the end of the operation, you can tell all the 10 sponge with the radio frequency, the indicator is outside the patient, nothing is inside the patient. Like that, we can go for a very accurate diagnosis. So the patient can be safely go home, and you can also have a good, comfortable night sleep, thanks to all this technology. Because you know, this is going to happen. This is only not in the Mission Impossible. Probably you might have seen the movie. Like that, we can insert a small chip inside each patient. It is going to happen if you like it or not. It will have all the information about the patient. So that patient need not carry any case sheet with him. As soon as a patient comes to your reception, you sitting in your own room, you'll know, okay, that patient A has just arrived, and we know about him because he had the hysterectomy about 2 weeks ago. He is allergic to penicillin, all those things, even though you don't know, because the chip inside is going to indicate in your computer in front all about the patient. So that's a magic. So you may need, I'm just trying to tell some fiction novel movie, but it is actually going to be a fact in reality. Okay? And also you know the imaging we are going to get. Already we are getting a very fantastic imaging, like an ultrasound image. With your cell phone, you can take a nice ultrasound image. All you need is a tiny probe. Because the sonologist getting a smaller and smaller machine, but better and better images. Thanks to the 3D, even a 4D images are happening, and there is no need for a CT scan, a contrast CT, because we know the problem of contrast is damage to the kidney, especially if the renal function is poor, especially when you give iodine contrast. But here, with gas-filled micro bubbles, you'll be able to get a contrast ultrasound. It is as good as CT. We have a contrast PET scan, 3D, and also open MRI, because MRI always find it is a claustrophobic. You can't lie in MRI for a long time. But it is going to be changing because new air MRIs, colorful pictures, easy to get. For example, nowadays, there is no need for a tissue diagnosis. If you have a liver lesion, whether the liver is fibroptic or a normal liver, we have to take a biopsy and see under microscope. So see there are better, non-invasive, simpler, pain-free way of making diagnosis rather than putting needles into the patient. Next is the most exciting thing for the postgraduates coming. That is learning everything not in the real world, but a virtual world. That is 20, 30 years ago, if you want to learn appendectomy, you stay with your professors for at least 2-3 years. Nowadays, we travel to place A to B, weekend courses. We see one lap hysterectomy, 5-10 cases in a day, weekend courses, and come back and operate. But those things are going to be past. Tomorrow, you need not travel anywhere. You stay in your own house. All you need is a virtual training, tele-mentoring. These are the two terminologies, if people may not know, will understand now. For example, we know as a surgeon or a doctor, the first year in your medicine, MBBS, is very, very difficult because you have to put up with the formalin smell, dissect all the dead bodies to understand the anatomy. No need for all those things. If you have something, goggles like this, Microsoft HoloLens or things like that, just wear them, okay? And if you want to study an elephant, elephant will walk right in front of you. That is called augmented reality. You can teach your children how a dolphin or how all the different animals, birds will move or will work. Same way, we can also teach an anatomy. You can go around your heart. you can go around the blood vessels. This is a different anatomy in a different perspective from a radiologist perspective.
But it's not just anatomy that could benefit from this technology. This could change how everyone learns. Imagine for a moment some of the other fields that could be changed.
In other words, you can dissect skin level, bone level, muscle level. You can read in depth what's happening in a patient very simply without wasting a human body. So this is what's happening. Even simple things like a rectal examination, you can teach your students without a patient having a problem of painful examination. So there are some, in other words, models available. And also operations. For example, nowadays, patients are asking, doctor, how many such operations you have done before? If you are going to do some difficult, challenging procedure, and the patient is bound to ask you or your junior colleagues. So you have to tell, I've trained properly, not only in patients, but also in a simulated environment. Because now there is a technology called immersive virtual surgery. What do you mean by that term? You just put the goggle, you feel completely immersed in a, not a real world, virtual world, as if you're inside the theater like this. You know what's happening, you turn, and you can see the gallbladder. You can start operating like this. So this is a very thing. In other words, you have the realistic experience. If you keep doing it 100 times, you feel like you have the confidence to do the next lap chole confidently. So that is what we say. All my juniors, please go through this virtual computer animated gallbladder, do about 50 to 100 times, then come and assist me and operate. Then that much more confident. So this is the way. And what we do, so, see, nowadays we know simple printers are in our hospital, but now the thing is going for a bioprinter. What do you mean by a bioprinter? It is a 3D printer that will print your heart, your kidney, or your liver, and put it in a small model or a trainer, and you start dissecting and train. For example, tomorrow I am going to remove a liver tumor. Similar model of the patient can be printed, put it in a box, and you train how to dissect it overnight. So next time when you operate in the real patient, you know all the troubles you are going to go through. So that's the way people, in other words, the previous day training can be more realistic if you have all the technology. And these things, don't think it is going to take a lot of time to come into India, because all these things are actually been done by most of the Indians sitting somewhere in America or somewhere. So all this technology is already coming into all the bigger hospitals in our country. So I'll skip this one. And the next important thing is, even more exciting, is called color-coded surgery. Because you know, when we operate neck, abdomen, when we see the anatomy books, we know vein means blue color, nerve means yellow color, because